So where are we?
So this is the lumbar spine.
Okay.
Okay, so this is L5, 4, 3, 2, and 1.
Okay.
Okay. These are the vertebral bodies. These are the vertebral discs.
Okay.
Okay. So with you, you have bulging discs at 3, 4, 5.
Okay.
Significantly at 4, 5.
Okay.
And again at L5S1. Looks like you even have a little bit of a tear at 4-5 in the disc.
All right.
And possibly at L5S1.
Okay.
Okay. You can see the disc bulging outward. Are your symptoms all on the left leg?
No, they go to the right
Both
too.
sides?
Yeah, both sides.
Okay. So this view is paper-thin slices going through you like this, right?
Okay.
This view is paper-thin slices going through you like this.
Gotcha.
This view is paper-thin slices going through like this.
Okay.
The yellow line represents in the other field, so this is that slice
Gotcha.
and that slice.
Okay.
And so as we work our way down to where your disc bulges are, so this is the vertebral body, so this is that bone right there.
All right.
Okay. And as we move down, we're going to watch the overlap of the disc. Okay.
All right.
And do you see how the overlap of the disc lines further out? Okay, as we move into this,
Yeah,
you see that?
Yeah.
And so over here on, this is your left side, so it's reversed. Okay. So this is the right, this is the left. Okay. You see how narrow this space right here becomes?
Yes.
Okay. And how, and this is where I say you have possibly even a little tear.
Okay.
So do you see the black that's still continuing out here? That's disc content.
Gotcha.
That's pushed into that foraminal opening that continues as we move down, because this slice is clear down here mid-body in the next vertebral body.
Okay. All right.
Now I'm just going to take you through, we're going to get you to the left side. So this is now that paper-thin slice. This is going through more so on the left-hand side.
Okay.
And we're looking at these openings right here. These are the foraminal openings where the nerves, so these are the nerves, the black dots.
Oh, okay.
Those are the nerves exiting out through the foraminal openings, okay?
Right.
Do you see how wide open these are up here? Look more like a jelly bean, and then we get down here, and now they look like a little keyhole.
Yeah, definitely.
That's because the disc is bulging into, the bottom half of that foraminal opening, and disc bulging is occupying the majority of that space at these levels. So the nerve gets pushed up into that upper 50% or even upper third, of that opening. Okay. And so there's pressure on the nerves, and so that will give you radicular pain that travels down your leg.
Yes.
L4 is going to be here and crossing over, right? L5, right? So every nerve has a distinct pattern, that it follows. And so those are problem areas. The other thing that you have, if you look down here, these are Tarlov cysts.
That's the cyst there.
Okay,
I know it's been mentioned before.
And so you don't just have one. Okay, so if we look in this view as I come down, so you can see the yellow slice. This represents that slice. So now as we come down to where we start to see the cyst, right? Boom, you have one forming right here on the right side and one forming on the left side.
They look big.
They are big.
Gosh sakes,
And these are the foraminal openings, These are, I believe, the S2 foraminal openings, so where the S2 nerves. So when I was asking you, do you have any, pain tight into the groin, into the scrotum, right? Anything like that? That's because the nerves that innervate those regions come out of sacrum. And so if there's pressure, from a cyst on a nerve, it can give you distinct pain. And so that's why I'm asking those questions. I want to know, are these cysts causing you problems with nerve pain?
Could you step out just 1 minute?
Sure, that's fine.
I'm sorry.
No, that's okay.
I've been castrated. I've lost my testicles, so
Okay.
there won't be any pain there.
Sure.
You know what I'm saying?
Yeah.
And I don't find any real distinct pain down in my groin area.
Okay. All right. So that's good information for us to have.
Okay.
So I want you paying attention. So even though testicles are not there,
Right.
okay, you can still have pain right in your scrotum,
Okay.
penis,
Mm.
okay, any problems with bowel movements,
Okay.
pain, in anywhere in the peritoneal space,
Right.
okay.
Right.
So I want you thinking about that as you're kind of going through, because, and I wish we were in a different room, because I've got models and pictures that show you what these nerves innervate, okay, and sometimes seeing that, it's like, well, yeah, I have pain right there.
Yeah.
Okay.
Yeah.
So that's important, but it isn't one cyst here; it's two.
Okay.
Okay.
Ben can come back in.
Okay. Ben, come on in. Okay. So these, if they're not a cause and playing into the pain, we don't want to mess with them. Okay. So to go in.
What do they consist of?
So fluid-filled little sac. Okay. But they can change in size. So sometimes we'll go in and do what are called transforaminal epidural steroid injections. We'll go in through the little opening. Okay. Do you want to grab the model, Ben?
Sure.
Just so I can show him. We can go in and do what are called transforaminal injections and put steroid in. And in doing so, because the needle is passing through a cyst, oftentimes it'll rupture.
Yeah.
That fluid will come off and it'll decompress the cyst. Okay?
No problems with the fluid coming out?
No. And if it's causing pain, that depressurization, typically patients will say, oh, that feels so much better.
Right.
The problem with that is, because we've punctured it, high probability it's going to come back again. It'll seal off. It'll fill up with fluid again.
Right.
But by doing an epidural and getting that relief, it tells you what life would be like if that cyst wasn't in there.
Gotcha.
But if you're not having symptoms that are really playing into that, then it's probably not worth going down that path. We just monitor them, watch them, and see if they become a problem. So when I say the openings, these are the openings that I'm talking about. These are where the S1, S2, S3, and S4 nerves come out. Okay, both anteriorly and posteriorly. There's a branch. Okay, and so when I talk about transforaminal, we're literally going in. The cyst for you is on the inside. There's bone covering it, so it's a cyst that's right in here where.
That seems like it'd be way intrusive.
Well, so we're going in with a very small needle. Okay, going right in through the opening. And that cyst, you can see, overlies. So normally, this opening, we would see it coming like this. So if I move up a level, I'm going to show you. So right here, do you see how big these openings are? Those are the S1 openings. Okay. So, and then as we move down, now these are, right?
Oh, yeah, it's
the
right
S2
in there.
openings.
Right.
So they're occupying the space inside this canal. Behind bone, but where those cysts are sitting right there and right there underneath bone. And it can be causing you pain. But if it's not, we leave them alone. Just because we see something doesn't mean it's something that has to be treated.
No,
and that's important.
Would that have anything to do with my legs, my lower limbs?
So typically, S1, if it were up at S1, S1 goes straight down the back of the leg. Okay. And so, yes, that could give you some. But I'm betting the problem that you're having with your legs is actually coming from right here and right here.
All right. So that's
these bulges are
T5, T4.
So L4-5.
Oh, L4-5.
And L5 S1.
Oh, yeah. Okay.
So the bottom two disc levels. You can see how it's tenting. Do you see this line right here, the black line?
Yes.
So that's called the thecal sac. It normally, if you look up above, it rests against bone all the way up. These bulges are significant enough that it's tenting or holding that membrane away. Okay. And you're even in contact with nerve roots as they So these spinal cord ends up here
Right.
on you.
Right.
These are all just pairs of nerves that come and exit, right? L5, 4, 3, 2, 1.
Okay.
Exiting as pairs that innervate the pelvis and the lower extremity,
Okay.
right? So you've got bulges that are in contact with nerve roots,
Okay.
causing central stenosis, right? Which is
All
this
right. All right.
an hourglass effect in the central canal, okay?
Oh, inside too.
And then it's also causing foraminal, so the little keyhole openings, because disc is occupying space, it's causing foraminal stenosis at those levels as well.
Okay.
And that's happening at 3, 4, 4, 5, and L5S1.
Okay.
Okay?
Yeah.
So, yeah, and here you can see the cysts again in
Oh,
this
yeah.
view.
Well, look at all the muscle. Is that muscle coming
Yeah.
out? Oh, I didn't know I was that muscular. I'm surprised the girls don't like me more.
Oh, boy.
Wow.
So, yeah, you can
Yeah.
really see and
Yeah, no
define
kidding.
them there, and we'll bring these back into view here. So that's the one on the left right there that we're seeing.
All right.
And now as we move in, you see it get even bigger on the right.
Dang.
And you can see that it's held underneath the bone of sacrum,
Yes.
right?
Yes.
Right here, you can see how it flattens it out and squashes it,
Yeah.
right?
Yeah.
So,
Wow.
Okay.
Yeah.
All right. So we did your injection last at L5S1.
Right.
So we did an injection at this level.
Uh-huh.
Okay.
Yeah.
What I would recommend is that we repeat your injection. Okay.
All right.
It only got you, you're saying, like 5 days?
Yeah.
And then it came back. Okay.
It's like once the lidocaine or whatever you put in there, once that wore off, then it's just kind
Okay,
of
so
back
that
to-
medicine only lasts for so lidocaine will last about an hour, Marcaine lasts about 3 hours.
All right.
So the steroid's doing more than you're giving credit for. It's just a matter of, is it going to give you relief long enough? But what I can tell you is this may be a big enough issue, right, that it's going to take bathing this area with an anti-inflammatory longer than just the 4 weeks that one dose will give you. So we may need to do more of them with some overlap so that we're extending the period. And then the alternative to that is getting a surgical consultation with a neurosurgeon to have them look at, not necessarily we're sending you to surgery, but have them look at your back and say, well, here's what's going on. This is what could be done.
Yes.
Is it in your best interest or not?
Yes.
That's a neurosurgeon and you discussion.
Okay.
Same thing. We may talk about at some point doing a transforaminal and seeing if when these are released and the pressure is off, do your symptoms change or not? Okay. So our goal is to put an anti-inflammatory in there and just reduce it down.
But I've always thought, and felt that, gosh, when it's squeezed down that far and everything, I mean, is there hope for it with just injections? I don't want to lose my legs. That's the biggest thing.
I totally get it. What I can tell you is we have backs that are in bad shape. I don't treat just an image.
Right,
okay?
right.
That's why we do the physical exam and we do everything, and then we make,
Right.
We take it all into effect.
Right.
We see people with backs that are terrible, that have very little symptoms. Okay. We have patients that have backs that look really, actually pretty darn good, that have dramatic symptoms. And what I can tell you is, without putting the steroid in there and giving it a chance, okay, the answer is no, it's not going to help you if we don't do anything.
Right. Yeah.
And that's why most insurance carriers want you to exhaust and try injections to the point that we're just not able to get anything out of it before we consider doing anything surgical. Because we have a lot of people that make dramatic changes for them.
Yeah.
Does it help and fix everyone? It's not gonna fix your back,
Right.
but it may get you to where we have you more mobile, you're doing more, you're not going backwards, you're going forwards, having less falls, more stability, able to participate in doing things daily.
Right.
Rather than
Yeah.
feeling like you're on a roller coaster going backwards.
Yeah.
Okay. So that would be my recommendation. Is I would recommend, we've done one here.
Right.
So everything here that comes through has to get through this point first.
Gotcha.
Okay. I would recommend that we do an injection at this level.
Okay.
That way we're driving steroid here and we've put steroid here, and do it at an overlap to where there's still some of both working to see if it gets you more improvement.
Okay.
Okay.
Now, can I still get a surgeon's consultation?
Absolutely.
And go forward with the steroids?
Absolutely.
Okay.
Yes. Absolutely.
All right.